Welcome back to the American College of Surgeons Bulletin Brief from the front lines, Surgeons' Voices. With me today is a voice we've heard before, a very renowned and respected voice, that of my dear friend, Dr. Rick Greene. Dr. Greene is the Medical Director of Data at the Levine Cancer Institute in North Carolina. He is also a former second vice president of the American College of Surgeons, served as the Commission on Cancer chair, and for many, many years has had a leadership role as editor of the AJCC staging manual, somebody very well qualified to talk about our topic today of the Commission on Cancer. Welcome back, Rick.
Steve, it's a pleasure to be with you. Thanks so much.
Always enjoy having you. And I always feel like it's a bit of role reversal given your history and radio interviews and your NPR show and your, of course, masterful job as MC of SAGES every year. So it's always kind of a bit fun to be the one interviewing you rather than on the other side of the microphone, as it were.
Well, I love your interviews for Bulletin Brief. I really do.
Well, thanks for indulging me. I must say I tried to pick up a lot of your tricks over the years as one of your students and big fans. So it's good to have you here. And the impetus for today's interview is the fact that on Friday, October 30th, the Commission on Cancer annual meeting was, like virtually every other meeting, virtually held online. I'd like to get some of your reflections, again, having chaired the CoC and been involved in the CoC for decades. How was that meeting compared to the in-person meeting for transmission of educational content?
Well, as you know, we usually have the meeting at the time of the clinical congress, so there's a lot of excitement and activity around that. I think this virtual meeting really accomplished everything it set out to do. And it was led by Larry Schulman, who was the outgoing chair of the commission. It featured a lot of the good work that the commission is doing. So I really feel it was a great meeting. The only thing is you can't network. You really like to see everybody who's been involved in the commission. And, the commission is made up of 58 organizations. So it's an amazing array of people who come to the Commission on Cancer meeting. So I miss seeing those people in person.
Perhaps you could expand a bit upon that subject, because many of our viewers and listeners may be in HPB surgery or trauma or orthopedics or who knows what, and may not be familiar with the CoC. So you mentioned 58 organizations. Maybe you can give us a little bit of a thumbnail sketch about the CoC history and function, as well as its breadth in terms of numbers of hospitals and patients.
Well, it's a great, and I've been surveying for the commission for almost 25 years now. And when I go in and meet with the leadership of the hospitals, I always start off by saying, this is not a surgical organization coming into your institution and telling you how to run your cancer program. This is the Commission on Cancer, which is made up of 58 organizations. And I think all of these organizations represent really the mainstream of what goes on in cancer. So I was very proud from 2004 to 2008 to chair the commission. And as you probably know, we've added organizations every year, so we're up to 58 now. And I think it really is true, because every organization brings something different to the commission. And the accreditation, which I've been involved in for many years, the standards have developed because of the input of organizations. For instance, the Oncology Nursing Society, they did the standards for oncology nursing. And other organizations like that have had major input. So I think this is what the commission really is like.
Okay, and the number of hospitals in the U.S. Which participate in CoC, or the percent of patients treated every year, could you give us an idea?
Sure, we're up to about 1,540 institutions. And this makes up about 24% of all acute care hospitals in the United States. But it's important to realize that in that 24%, we take care of 75% of all cancer patients. So 75% of all cancer is put into the National Cancer Database. I wish I could tell you that we put every patient into the National Cancer Database, and maybe that's a goal, but right now it's 75%, and we're very proud of that.
So how many tens of millions of patients' data are now in the NCDB?
We're up to about 37 million cases in the NCDB. Very, very robust database. And what we try to do is make sure that people in academic institutions become participant user file users. In other words, use the data to write their research papers. And I was involved in the late 80s when the NCDB started with the American Cancer Society, the American College of Surgeons. So we're really proud that many of the papers coming out use NCDB data, just as the paper that was featured yesterday or the other day at the Commission on Cancer meeting.
Perhaps you could tell us a little bit about that paper.
Well, it's a very interesting paper because, first of all, the groundwork is that for the first time in our new standards, we put out standards suggesting that the way a surgical operation is done for a cancer patient is important to outcomes. And so we have 6 different types of cancer operations now that we're going to look at starting in 2022 and into 2023 when we start accrediting institutions for our new standards. And one of those, as you well know, Steve, is carcinoma of the colon and also the rectum. And so what this paper did, it looked at videos and how operations were done by videos by surgeons and compared the outcomes to the NCDB data for colon cancer. And obviously, if you do a left colectomy appropriately, with all of the vascular involvement that it takes to do a good left colectomy, your nodal counts will be better. And that's what we've always felt. The 12 node rule that we instituted in the AJCC is very important. So the paper itself, which Heidi Nelson and Carl Villamoria and the group from our NCDB was really instructive in doing this and showed that you can actually equate outcomes by the way the operation is done. Now, obviously, we're not going into hospitals and asking for videos these days, but it may be that at some point this will be another standard that we'll look at.
So what the paper showed is that it makes a difference in terms of who does the operation based upon how that person performs the operation, which in fact may be due to training, maybe due to volume, we're not sure. And this is certainly a topic that's been explored at many levels in cancer programs. Can you talk about some of the other cancers for which the NCDB is allowing us to accrue similar data?
Absolutely. One of the areas, of course, is breast cancer. So there are 2 standards now. One, how to do a sentinel node biopsy for breast cancer and how to do an axillary dissection. So when I go in now to look at hospitals, we're going to look at synoptic operative reports, which specifically will tell us what are the steps to do a good sentinel node resection and what are the steps to do an axillary resection. The next one would be melanoma. In other words, if you know the depth of penetration of the melanoma, what's the width of the margin that you should resect? So this should be well stated by the surgeon. And then, of course, as I mentioned, colon cancer, rectal cancer. Now, rectal cancer and also pulmonary resection will be equated by the pathology report, not necessarily the synoptic operative report. So obviously, as you well know, the pathologist will be looking at the TME, the total mesorectal excision, how well it's done. They'll look at the nodal counts. And in pulmonary resection, we're going to look at the number of nodes and where those nodes were taken from in the stages of the pulmonary resection. So it's a very exciting time.
And if a surgeon wanted to ensure that she or he were following the steps, could you maybe tell us a little bit about what the cancer programs are doing for having the operative standards available for people to look at?
Absolutely. First of all, a new group, the Operative Standards for Cancer Surgery, under Matthew Katz, has been formed, and they're very active. And we have 2 volumes now that have come out, soon to be 3, and eventually 4 volumes of how to do a cancer operation. So the message that I want to get forward to institutions when I go to see them is that you need to get that book. You need to have all of the surgeons, and especially the trainees, the fellows, and the residents, looking at those volumes and seeing how to do an operative cancer resection. And it really covers the whole waterfront of all of the solid tumors that we do in adults.
And do you think as the data are captured and standardized, well, captured by the NCDB, then perhaps standardized through standard revisions, how does the AJCC then deal with those data if it becomes apparent that something we weren't looking at now is important, maybe in rectal cancer, circumferential resection margins, or quality of total mesorectal excision? How is that taken into account by the AJCC?
Right. Well, of course, one of the real tools that our task forces use when they look at new staging criteria is the NCDB data. So we look at all of the data coming in from the institutions. We look at nodal counts. We look at biological markers. We look at molecular markers that are currently not in staging, but are captured by the abstracts that the registrars do. And that's why I personally am involved at my institution and make sure that there's quality data coming into the NCDB. So the AJCC really goes to the granular material that comes through that to look at. For instance, we just came out with a new staging criteria for cervix cancer. That's the first one that's been launched into the 9th version. And so new staging for cervix cancer was based on the staging. Of course, that's FIGO staging in GYN oncology, but it's also AJCC staging. The next one we're looking at is breast. So the task force in breast cancer is always looking at new ways of looking at staging criteria. So yes, it's very important, and it's the NCDB is hand in hand with how staging is done throughout the world now.
And speaking of throughout the world, I would imagine that the NCDB is the largest cancer database in the world.
Absolutely. And as you probably know, we have accredited institutions now outside of North America, outside of the United States. And this is always, even when I was CoC chair, this was one of my goals, to try to export our accreditation program around the world. And hopefully that will continue to be done under the reign of Tim Mullett as the new CoC chair.
I certainly hope so. And I think that the virtual site visit format may facilitate that type of accreditation in not only cancer, but in many other programs as we look across all the college quality programs of trauma and pediatrics and bariatrics and rectal cancer, CoC, and so on. It may facilitate more international engagement.
Well, of course, I am involved in the virtual surveys, but I will tell you, nothing beats an in-person survey.
No doubt. Just thinking about some of the logistics for international travel, particularly in this COVID-19 era.
Right.
Any other thoughts with which you'd like to leave us?
Well, I would just say the exciting thing for me now, I'm on the group that's looking at the 100th anniversary of the commission. And what we hope to do is at the Clinical Congress for 2021, we want to sort of launch a year of celebration for the anniversary. And as you know, you'll probably be hearing a lot more of that, but I'm excited because again, I wasn't there in 1922. Some people think I was, but we're going to have an exciting year lasting through 2022.
Well, thanks very much. I certainly hope that we're there together in person celebrating in October of 2021, the launch of that year-long celebration. Thanks for all you do for the commission, for us as surgeons, our cancer patients throughout the world, and thanks again for your time today.
Steve, thanks for having me.